Hello class, our project is on trisomy 18, also known as Edwards syndrome. In this presentation, our group is Ashley, Jasmine, Keisha, and me, Patricia. How do we identify trisomy 18? There are two ways that we can do this, one of them being prenatal testing. When a mother is expecting, we do routine screenings, which include maternal serum screening between the first or second trimester. Another way we can test is diagnostic, which we take chorionic villus sampling or amniocentesis. During an ultrasound, we can see signs of trisomy 18, very little fetal activity, single artery in the umbilical cord, a small placenta. Fetus is surrounded by too much amniotic fluid. For testing at birth, we can do genetic testing. Its karyotype provides conclusivity of extra chromosome. Also, we can recognize it by physical features. Distinct facial features they will have would be a small head and jaw, low set ears, prominent back of head. Also, the hand and feet abnormalities. You would see overlapping fingers and then rocker bottom feet. What impact does this problem have on the pediatric population? The impact this has on our population. Affected infants suffer of a multitude of physical anomalies and significant psychomotor developmental delay. The majority of these infants die before reaching their first birthday. Only 5 to 10% of them survive longer. This leads to early death. It is very rare making it to adulthood. There are some cases where they do reach adulthood. One example being Megan Hayes. She is the oldest known individual in the United States and second oldest in the world that has trisomy 18, and she recently turned 40 years old. She's still alive today. She is a member of SOFT, which we will bring up in the resources slide. She's still living in Oklahoma with both of her parents. This is why a lot of parents don't know what is going to happen with their children. A lot of times it is believed that they will die. According to research, like 5 to 10% will survive longer. She is part of that percentage. She is living at 40 years old.
Okay, for the nurses' roles. So, in addressing the concerns related to trisomy 18 in the pediatric population, us as nurses, we play a pivotal role that extends across professional, legal, and moral dimensions. So, as you see on this slide, we presented a few for each category, and I'm just going to summarize it fairly quickly. So, us as nurses, we provide holistic care to children with trisomy 18. We're addressing not only their physical health needs, but we're also attending to the psychosocial and emotional aspects that are affecting both the child and their family. So acting as advocates, us as nurses, we ensure that the unique needs and preferences of these children are considered in our care planning and their decision-making processes. And then our education, it becomes a crucial responsibility. Because us as nurses, we're guiding families about their condition, their treatment options, and their available support services, ultimately empowering them to make informed decisions. In their legal role, us as nurses, we have to be meticulous in obtaining informed consent, because this means that we're ensuring that the parents or the legal guardians are fully aware of the implications, potential outcomes, and risks that could be associated with any medical intervention that we're doing for their child. It's imperative that we have rigorous documentation of the child's health status, the care that we provided, the communication we've had with the family, because this also ensures that we're compliant with legal standards and that we're facilitating continuity of care. When we're adhering to the state and federal regulations that are governing pediatric care, just overall, particularly for those with genetic conditions like trisomy 18, but just overall, that just guarantees that the delivery of care that we're giving is safe and it's ethical. And lastly, for our moral roles, The moral dimension of nursing care involves navigating complex ethical dilemmas, especially in the end-of-life decisions for children with trisomy 18. So ultimately, that just means that we're engaging in ethical decision-making processes, making sure that we're respecting the values and the beliefs of the child and their family. We want to make sure that we're compassionate and providing our care, making sure that we're approaching the responsibilities that we have with empathy, sensitivity, and a commitment preserving the dignity and quality of life for the child. We have to make sure that we're recognizing and respecting the cultural diversity. That's an integral part of, making sure that our care plans are integrating the unique beliefs and the practices of the families involved. Okay, so with trisomy 18, we know that the syndrome has profound effects on the overall health and well-being of the child throughout their development. So I'm just going to kind of review real quick the age-related health needs and their stages of growth. So in infancies, that's between 0 to 2 years, we're going to see that they have some cardiac challenges, congenital heart defects, respiratory issues, difficulty breathing, feeding difficulties that can impact their nutritional intake. All of this is a critical period that can affect their overall health and well-being. Looking into early childhood, between 2 and 6 years, you're going to be able to see that they have developmental delays like cognitive impairments, educational challenges, difficulty accessing appropriate educational resources, things like that.
What are some preventive and healthcare needs?
Preventative and healthcare needs. Trisomy 18 is a defect, and it does take place when the fetus is first developing from the egg and the sperm. There's nothing we can do to prevent trisomy 18. It is just by chance that the chromosomes did not separate the way they're supposed to, and then we end up with 3 sets of chromosome 18s. When the parents are pregnant and going through the ultrasounds, they might see abnormalities in the scan, and then they would go through genetic testing. This is when trisomy 18 is going to be diagnosed. We can provide support to the parents and present the options for the decisions the parents must take. Some options that can be presented would be to terminate the pregnancy, carry the rest of the pregnancy. The statistics of a baby being stillborn, or being born to only live a couple days to months, and only 5 to 10% being alive for longer than that.
Okay, for resources in California, there is the California Department of Public Health, which they provide education about prenatal screening programs here in California, and they also provide result information. The information provided informs parents further about the possible diagnosis, as well as further prenatal screenings that will be needed to confirm the diagnosis. They also provide a brief description about each additional screening procedure that will be needed to confirm the diagnosis. Then nationally, for a lot of families, is the Chromosome 18 Registry and Research Society. They provide resources for you to find, for families to find like help with care, different supplies that families would need. And then there's SOFT, and that's a support organization for families that have a child diagnosed with trisomy or trisomy. So this is just a support group for families, and they also provide the same resources that Chromosome 18 provides. So some of the long-term adverse effects, most of them are fatal to all trisomy syndromes. So we have some medical complications like congenital heart defects, respiratory issues, so they have difficulty breathing, recurrent infections. They'll have severe intellectual disabilities, severe hypotonia. So they're going to be very weak, like loss of muscle tone. They'll have growth and nutrition issues, so feeding difficulties, challenges leading to nutritional concerns and growth deficits. They'll have a limited life expectancy because of these other complications that go in with this disease process. They'll be in an immunocompromised state, and they'll also have recurrent hospitalizations.
So with the diagnosis of trisomy 18, the outcome is high for a minimal chance of life. Some babies live months after being discharged and will not have the possibility of living those months if the pregnancy was ended. This being said, some would consider continuing the pregnancy as futile and might push for termination. This is a decision the parents have to make. This leads us to consider a couple moral conflicts. Is it ethical to continue the pregnancy with a confirmed diagnosis, knowing your child will not live a long life and may suffer during those few months? And then there's the debate for abortion. Is it ethical to abort the baby without seeing the outcome through? If maybe your child might be the exception and thrive, or if maybe nature should be allowed to take its course. In addition to this, there's also the question if parents should be allowed to consider termination if there is already a 95% chance that miscarriage will occur. According to Wilkinson's 2014 article, 80% of obstetricians believe that labeling this disease as lethal may interrupt the decision-making process of parents. By this, he means that parents may not believe they have the freedom to choose the course of their baby's outcome if death is automatically assumed to occur. In her theory of caring, Jean Watson emphasizes the importance of human connection, holistic care, and the promotion of well-being. This is especially applicable to trisomy 18 due to its complex and incurable nature. Because treatment is entirely comfort care of the neonate, nursing care should be focused on promoting the baby's well-being as well as that of the parents. Here are some potential nursing diagnoses to consider. Concerning the physiological nature, there is ineffective airway clearance related to increased work of breathing as evidenced by altered respiratory rhythm, decreased cardiac output related to cardiac dysfunction as evidenced by altered heart rhythm, and risk for disturbed maternal-fetal dyad related to pregnancy complication as evidenced by compromised fetal oxygen transport. In regards to environmental and community integration, there is interrupted family processes related to altered family role as evidenced by assigned tasks change, and readiness for enhanced family coping as evidenced by expression of desire to choose experiences that optimize wellness. Considering the parent's self-concept concern is parental role conflict related to intimidation by restrictive modalities as evidenced by anxiety. And in terms of interdependence and self-reliance, there is delayed infant motor development related to decreased muscle tone, and delayed child development related to congenital disorder as evidenced by failure to achieve expected milestones.